Welcome to the inaugural interview episode of the Knife Down podcast. Today, I have an interview with preventive medicine expert Dr. Ford Brewer, and it's a treat because it's actually a double feature. I am dropping this interview with him today, but on his channel at Dr. Ford Brewer, you will also find the interview that I did with him. So I hope you guys really enjoy this story of how Dr. Brewer got into preventive medicine and why he and I are both so passionate about what we do. Please let us know what you think in the comments below and hit up at Dr. Ford Brewer to see the second part of this great double feature. Well, thank you, Dr. Brewer, for being here. I am so excited to have you as my first guest on the Knife Down podcast. Welcome.
Oh, well, thank you, Dr. Johnston. I didn't know I was your first guest.
Yes, it's a great honor to have you, and I'm excited to dive into our conversation today because you were originally trained, as I understand it, as an emergency medicine physician, but quickly turned to prevention. Tell me a little bit about that journey for you.
Well, I'm not exactly sure where to start. I think the problem with emergency medicine was, well, we can get to that one later. But the problem with emergency medicine was, I remember a fellow in his mid 50s coming in with a heart attack, and I was seeing yet another one of these, and it was like, this could have, should have, would have never happened had he done what he needed to do. And it sounds like patient blaming, but it wasn't patient blaming, because the next thing I said was, um, I can go on and play ER doctor like on the TV for the rest of my life. And by the way, that was only about 30 years before ER ever hit TV. I'm that old. Or I can actually focus on doing something for my patients. And if it's about me, then I'll continue this. But if it's about my patients, I need to go back and learn how to do prevention. Because I knew that I was going to end up having to do at least one of the two things that I said I would never, ever, ever want to do. And that one thing was being a teacher.
And what was the other one?
Being a bean counter. And sure enough, so I got the best place. I was very fortunate. I was able to get into the best place in the world for that, Johns Hopkins. And sure enough, one of the things they say at Johns Hopkins, we talked about what we call denominator medicine. And that sounds really technical, but the bottom line is it's not so much about one patient as it is what's different about all the people that have a disease process from everybody else. And that's where denominators and all the technical bean counting come in. On the teacher part, I don't. Did you ever get to see any of the Peanuts movies?
Yeah.
Do you remember the teacher that they had in the Peanuts movies? Exactly right. That was my view of teachers. I did well in school, but it was like, I don't know if it was the Deep South or what it was, but most of my teachers were like, "Rah, rah, rah, rah," and I just didn't want to do that for a living.
I understand.
But at the end of the day, guess what? When I got to Hopkins, I was a bean counter all day, every day. It was science, 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 looking at every one of the technical problems. And if we get to this issue of cholesterol versus other things causing heart attacks, we'll get to one of the key science issues.
Yeah,
Um,
we'll get there for sure.
Causation is not the same thing as correlation, and cholesterol, where that comes to be. But guess what I'm doing now? On the channel, it's all about being a teacher.
Yeah,
So
I
I
mean,
get
there are people who believe that really the role of a physician in general is that of teacher. The other
Well,
part though that's fascinating for me is that you then, you've been in the prevention space a long time, but it took a very personal turn for you. I've seen your content on reversing your own plaque. What did that discovery of advanced arterial age in yourself, how did that transform your practice?
well, that's a great question. I appreciate you uh, offering me an opportunity to tell my origin story. And thanks for having me on your show. Um, so I think I'm a microcosm of medicine. Way back in the dark ages when we were using leeches and Hippocrates was making it through school, and I was making it through school. We all knew that diabetes will rot your arteries.
Hmm.
And but I remember, for example, where I interned. I interned at Charity Hospital in New Orleans, and I would go from you go into the clinic, the blood pressure clinic, the internal medicine clinic. You're managing blood pressure and cholesterol all day in the clinic, and then you do a diabetes rotation, and you know that these people are rotting their arteries, their kidneys, their eyes, their
Yep.
brains, every part of their body, only the parts of their body that have arteries. And you would know what that means.
Yeah, that would be every part of the body.
Every part of the body. Um, so we knew that the diabetes rotted your arteries faster than anything else. But then you go over to internal medicine rotations and you really treat cholesterol. So what's the disconnect there? Well, then I fast forward over 30 years, closer to 40 years, and I've gone to I've done the ER thing that I told you about. I've gone to Johns Hopkins. I did well. I ended up running the program in prevention, and I actually walked the walk. And I stayed thin. I worked out. I ran. At that point in time, we didn't understand what we understand now about metabolic disease. So I stayed low fat on my diet. I did long, slow distances. I did marathons and ultra marathons. I really didn't do that much resistance training, didn't do that much HIIT training. And again, I stayed away from fat, not so much
Hmm.
carbs.
Yeah, I was raised on those little green Snackwell cookies. It was great.
Yeah. Yeah. And was it Entenmann's that, low fat cookies
Yeah,
where they just really
them
carved
too.
it up? And so I had retired a couple of times. This is like my second retirement or third. Um, I was age 57, and some friends of mine said, we want you to come listen to this guy. And his name was Brad Bale. Um, and I started listening to him, and he started talking more about um, inflammation
Now,
and
how early
vascular
was this? Was
disease.
this before Bale Denine was actually its own method? Was this like the good old days before they were like a whole system?
This was 10 years ago, 11
Okay.
years ago. So
So you
I,
may have to introduce Dr. Bale for those who are not familiar with Brad Bale and Amy Denine.
what's that? You want me to introduce him?
Well, just mention the fact that they have an approach to cardiovascular disease that both you and I are familiar with and incorporate in our practices, but I'm not sure how widely known they are.
Actually, Brad got well known when what was a was it Larry King? Did Larry King have a heart attack? It was
Great
one of these
question.
well-known guys had a heart attack. Oh no, he was on Larry King. I forgot who it was that had the heart attack, but he was on the Larry King show with two other docs, and he brought a very fresh, very interesting, very not mainstream view, and he was
Hmm.
saying he didn't think it was all cholesterol. And I've learned a heck of a lot from Brad. Brad was in my clinics for a while. I was in his training program for a while. Like I said, learned a whole lot from him and Amy. And I had him on the show again, a couple of months ago.
Hmm.
They've
Yep.
done the Lord's work in terms of taking people um, taking doctors and dentists and retraining them to look with different sets of eyes at cardiovascular disease.
Completely agree. Yeah.
Anyhow, I was at one of their, so I had some friends who said, well, Ford, you've just retired again. What are you doing? And I said, nothing so much right now. And they said, well, why don't you come by? We're interested in this guy named Bale, and we'd love for you to, we know that you know prevention, and he talks about prevention all the time. So come take a look. And immediately I had some issues with Brad and Amy because they had too much of a detailed internist look. It was like, don't guess, test. So they just tested and tested and tested. My whole approach to medicine, even from my internship way back in 1981, was doctors did too many tests. And my focus was, and my favorite quote in medicine, it still is, from William Osler. He was sitting in that oak-lined amphitheater, grand rounds at Hopkins.
Yeah. Yeah.
And the young doc was trying to present a patient, and he was known for being a hothead, Osler was. And he finally just got fed up with it. He jumped up, slammed his hand on the desk and said, Doc, if you'll just listen, the patient's telling you his diagnosis. And I still feel that's the same issue.
I agree. I love that quote.
Yeah. Doctors don't listen enough. So anyhow, I'm trying to remember where I was.
So we were going to talk about, how your own discovery of plaque in your arteries after you had done the work for so many years and walked the walk in prevention, like what transformed in your own practice, in your own thoughts about prevention when you discovered your own plaque.
So here's what happened. So even though my first impression of Brad and Amy was they did too much testing. Patients just need to know what's going on. They don't need all the testing. So Brad and Amy said, hey, we're very impressed with your background. We'd love to hear your opinion. Here, why don't you come out to one of our conferences? And so it was a 3-day conference. And when I was there were a couple of groups that did CIMT. And that's how you and I met, by the way, parenthetically, because you know how to do CIMT. And we can talk about that a little bit later if you want.
For sure.
But this is what got me hooked. So these guys were out doing CIMT for free for attendees of the conference. I hopped up on the table. Both tables got CIMTs from both groups. And again, I'll go back and remind you, I walked the walk. I stayed thin. I worked out. I never ate fat. I did some things that I've changed dramatically since finding this out. But I expected to get a clean bill of health, clean slate, no plaque, and then do my victory lap at dinner that night. And both of them said, we think you got some plaque. So here I was, age 57. It's not a bad time to have plaque. I'm not embarrassed about it now, but I was frustrated then. And then, it took me a couple of months to get over that because my response was, dang, as much running as I've done, I never even bought a Lazy Boy recliner because I just wasn't going to do it. And you see now I'm still, I do a stand-up desk.
Yeah, me too.
Are you standing up?
I am. I
didn't know that. You look like you're sitting. Very good.
I'm standing. We're standing together. More ways than one.
So it finally began to dawn on me 3 or 4 weeks later that, okay, you know what? Okay, I've got plaque. That means I've got risk. That means I've been through risk that I didn't even know I was going through. And I thought I was doing all the right things. Maybe I need to adjust some stuff. And, no, for the past month when I've been mad about this, it's not true. I could have, would have, should have just sat on the couch and watched TV and ate Twinkies all the time. Had I done that, I would likely to be not just having plaque, but could have been already dead.
Sure.
And so it's the next thing that happened was, Brad and Amy focus on inflammation a lot. They don't quite focus as much on the major cause of inflammation as I do, and that is metabolic disease.
Mm-hmm.
So as that starts to take the story back to what is it now? 45 years ago when I was at New Orleans, and I would go to the internal medicine clinic and try to help people lower their cholesterol level, but then go to diabetes clinic and just know that they were rotting their arteries. And so now you start to put some things together. What I didn't know 40 years ago and what we know now, the rest of the medical community is beginning to understand. And that is, there's tons and tons and tons of metabolic disease, and we just haven't seen it.
Right.
If you look at the last U.S. Census, there's a test that they do with it. They do a bunch of partner studies that go deeper, but not on the whole population, like small studies. One of them is called NHANES, National Health and Nutrition Examination Survey, where they actually do a really bad test for metabolic disease, a test called A1C. If you ask doctors how they diagnose diabetes, what portion would you say would answer A1C?
I would say probably 90% or greater use that as the criteria. Now, we both know that there are a couple more in terms of fasting glucose in response to an oral glucose tolerance test, but that A1C, that average measure of blood sugar over the last 3 months, I think is probably what more than 90% of current physicians are using. What do you think?
Yeah, exactly. And I would say it's more like 95, 98% will say it's A1C. Even the American Diabetes Association in their research white papers will say A1C misses about half of the diagnoses. And the American Association of Clinical Endocrinologists says, don't use A1C to diagnose this because it's hemoglobin. It's a hemoglobin test and things impact hemoglobin. But that's getting a little bit too deep. The whole
Well,
point
and then how many patients show up to your clinic and say, well, my doctor said I have prediabetes, but there's nothing to do about it yet. I'm still under an A1C of 6.5. We're just going to watch it. How often do you hear that one? Because I get that one a lot.
All the time. Or my doc said I had a touch of sugar, and I knew that I really didn't, and watch your sugar. So, and I knew that I really didn't use that much sugar. Maybe a little bit too much sugar in my tea or my coffee. So I backed off on that and thought I was fine. Even though he was having 2 bowls of cereal, Cheerios, with his coffee.
Yeah,
But anyhow, in
a
the
couple of
last
sweet teas in the afternoon.
What's that?
With some sweet tea in the afternoon.
That's right, at least in my part of the country.
So do you think that,
Go
ahead, sorry.
I was just going to make the point that in the last NHANES, the last U.S. Census, they took things like A1C and they looked to see just how common is metabolic disease, prediabetes. And they saw that of the population 18 and older, we're not talking about 60 and older. We know this happens more as you age, and that aging is the number one risk factor here, but even bigger than obesity or genetics. By the time we're 18 and older, over half of us, 52% of us, have prediabetes.
Wow.
And so it's like, oh my gosh, maybe there's a problem here. Maybe cholesterol raises every time you start getting metabolic disease, but nobody knows how to diagnose metabolic disease. And that's an issue there too.
So how did you have metabolic disease despite being a distance runner and somebody who paid attention to their nutrition? How did that happen?
Well, they've researched this too. Docs don't know how to diagnose it, and I was not the only one. If you look, folks at Hopkins, Harvard, and a couple of other places have looked at this, and they've said, what is your typical doctor's knowledge of prediabetes? And this was not orthopedists and surgeons, people that might not, and no slam on you, I know you know a heck of a lot more about this space because of what you do. But they looked at the group at Hopkins, for example, looked at internists, family practitioners, cardiologists, and they said, they just asked them how they diagnosed prediabetes, what they did when they found prediabetes. And they found of this group, the group that that we rely on most to diagnose prediabetes, only a quarter of them knew how to do it. So it's been right there in front of our nose, in front of us for decades, and yet we've missed it. We thought that cholesterol was causing this problem, and it's because cholesterol does correlate. Whenever your metabolic disease does go up, you tend to get an increase in cholesterol.
And so are you talking about total cholesterol here? Are you talking about LDL-C? Are you talking about triglycerides, ApoB? Help us kind of dive a little deeper into that part of it.
Well, okay. But I will, before we dive in, I'll just answer your question. No, I'm talking about, quote, bad cholesterol, end quote, that LDL. And as you hear a whole lot these days, ApoB. Oh, no, it's not. You hear the docs that are still clinging to the cholesterol theory saying, no, it's not cholesterol, it's not LDL, it's ApoB. Tom Schneiderman wrote the article that Peter Attia refers to, and he's had Tom on his channel a couple of times. And Peter's a good example of one of those people that still hangs on to the LDL theory. And I'm not saying that LDL doesn't matter, by the way. I'm just saying that it doesn't matter nearly as much as learning how to diagnose metabolic disease.
Yeah, we are in agreement on that.
What's that?
Yeah, we agree on that. I mean, I think the sum total of the epidemiologic data suggest that even, especially in patients who have plaque, there is a component of reversing plaque that is relevant for ApoB and LDL-C, but the medications that do that also seem to lower arterial inflammation and do a number of other sort of pleiotropic or off-target things. And, it does reverse the plaque, but does that mean that we should lower, we should put it in the drinking water? Should everybody's LDL-C be as low as possible all the time? Well, if there were no other consequences to that, I suppose, but there are some, and it doesn't negate the far and away greater impact of metabolic disease, right?
It's a good point. And this whole thing about statin intolerance and statin fear, I think statin fear is far more common than true statin intolerance. But because I use statin, I'm very public about when and where I use statins. And the reality is I don't use them to lower LDL. And I use them probably about 10% of the time most docs would, and I use extremely low doses. So I just don't tend to see the problems that you're describing. But I get a lot of statin fear
me too.
People.
And what, I think that it's important to acknowledge that, especially, for example, within the keto and low carb community, there are some very vocal voices who are talking about the fact that the data supporting statin therapy, especially in primary prevention for folks that do not have significant plaque or certainly have not yet had an event, is not that compelling in terms of numbers needed to treat and risk of new onset diabetes and insulin resistance and all of these things. So how have you, especially as somebody who's personally taken this medication, right? How do you think about the risks of these medications versus the benefits in somebody who already has plaque?
Well, you used the term pleiotropic a few minutes ago. Your viewership understands that term?
You should help them out.
Okay, so it's the term pleo was used to name the Pleiades, and that's most people haven't heard of the Pleiades either. The Pleiades is a constellation. It was named after the seven sisters, so it's like seven stars. And no, I couldn't identify it either. I just know it because of the term Pleiades, and I'm often in a position of trying to explain what does pleiotropic mean. Pleiotropic means many, and as you mentioned before, it means an impact that you weren't really thinking about when you started all of this. And that's the point here. I use statins in a very small level for far fewer people than most docs for the pleiotropic effect. And what do I mean by all that? So some very smart guys at Harvard, I think it was what Brigham and Women's, discovered way back over 30 years ago. They were looking at some studies like the Waskoff studies, West of Scotland trials, and a couple of other studies. And they said, it doesn't look to us like people with low cholesterol are protected from heart attacks, but it does look like people on statins are protected from heart attacks, whether their cholesterol is low or high. The name for those guys' names were Gavin Blake and Paul Ridker. If any of your folks want to dig deeper, they continued to look deeper at the evidence, and they said, they were saying, we think it may be something different from cholesterol. We think that statins may help by actually decreasing inflammation. And that was where, Brad picked up on that. To get back to the Brad story, that was what Brad picked up on decades ago and has been doing the Lord's work, helping doctors realize that, yep, it's true. Now, what's interesting is the cardiology community has known that the vascular inflammation is a thing. And you're not nearly as old as I am. I'm 68, and like I said, I started in 81. And for those of us who grew up getting hammered daily on multiple times per day on, it's not, it's cholesterol, that's all it is, LDL. It was hard for us to wrap our head around inflammation because we're very, very comfortable with inflammation on a wound, inflammation from an infection, but inflammation in the arteries just did not make sense. So I'm going to jump for a second to another story, a fellow named Tim Russert. You know that story?
You should tell it.
So he was the most well-known interviewer on Meet the Press. He was very, very well loved. He was an internationally recognized person. He died of a heart attack, and everybody was surprised about it. They thought he was in great shape, etc. But the point behind Tim Russert was they did an autopsy. And the guys that did the autopsy said, when you get inside his arteries, here's the quote, the inside of his arteries looked like the face of a teenager with acne. You've got all of these little pus pockets in his arteries.
Yuck.
And that's the point. It is inflammation. Those of us that grew up in my era never could wrap their head around it. It took me a long time when I started hearing it. But yeah, that's what was going on. And so if you go back to some of the stuff that you quoted a minute ago about plaque, it's the soft plaque that does it. And sure enough, the American Heart Association said, what was it, 5 years ago or more now? They've said, if you don't have plaque, you don't need a statin. And that, when you unpack that means a whole lot. It's as you probably also know, most internists don't know that. They don't know that their own standards committee has said that. And as you probably also know, because of your expertise in CIMT, which is way beyond mine, that then they screwed up again because they said, okay, if you've got a 0 calcium score, that means there's no chance you have any plaque, so you don't need a statin.
I love that one, especially for my patients in their 40s and early 50s.
Yeah.
Because again, right, this is, I'm gonna spell this out for folks who may not know, right? Calcium probably represents 20 to 30% of plaque in a person who has calcium, but it's late, right? Plaque is an evolving, it's almost like an organ of its own, and it's fresh and new and early, then it's soft and vulnerable. Eventually, if we can stabilize that plaque, sometimes it regresses, but sometimes it calcifies. And I tell my patients that's like paving over a pothole, right? It's just new some concrete over top of it so that you don't have this enormous hole that continues to erode. But calcium's not really the demon here.
Yeah, it's unfortunate. Even people that began to understand the whole issue of plaque is the risk, not LDL, they still get tripped up by the whole calcium
Yeah.
discussion.
And the other thing that actually I learned from Brad was this idea that it takes way less of this medication than we think to get arterial inflammation down. So when we're talking about things like rosuvastatin, you and I are both a fan of very low dose. And Brad was telling us in one of his teaching conferences that, in fact, there were unpublished data. Like the lowest prescription dose of rosuvastatin is 5 milligrams, but there were data that even as low as 1 milligram when they were testing this could impact vascular inflammation. And you'll get about 80% of the benefit of that medication at the lowest dose daily, or even maybe 3 days a week. So I think that that is, as we talk about what the guidelines, I'm forced in the direction of guidelines in my patients who have terrible PAD, high intensity statin therapy, right? 20 or 40 milligrams of that medication. And it saddens me because I know we can get most of the benefit of that at a fraction of that dose.
No question. You mentioned PAD. I'm sure your folks know what that means.
Yeah, they're used to talking, listen to me drone on and on about plaque in the blood vessels in the legs or in the neck, peripheral arterial disease. You're talking a lot about vascular disease in the heart for heart attack. I had somebody tell me at a conference the other day, well, the stroke shouldn't be considered major adverse cardiac event because you can't get plaque from the heart into the brain. And so stroke isn't a cardiac event. And I felt like getting up to the mic and saying, well, would you rather have a disabling stroke or a disabling heart attack? I'd actually personally rather have the heart attack. And that ignores the fact that this is a systemic disease. And he also said CIMT is a bad test because plaque in the neck arteries doesn't correlate with plaque in the coronary arteries. And that's all we care about. What would you say to that?
Oh, don't get me started. It's this whole thing about cardiovascular disease, as opposed to just saying vascular disease, is as bad uh, a whiff, a mistake, a giant error, a disaster, as the whole thing of thinking that it's all LDL.
Yeah.
Again, the problem is right in front of us and we miss it. This is not heart disease. This is vascular disease.
Mm-hmm.
Vascular disease, it's not just your heart, it's your brain, it's the back of your eyeballs, it's your kidneys. For men, it's your erectile mechanisms. What am I missing here? Those are the big
Again,
ones.
every organ, your legs, your arms. I think the brain for many of us is the one that really, really gets a lot of attention. And people start talking about, well, it's Alzheimer's isn't a vascular disease. No, but it's a metabolic one. And a lot of dementia is actually vascular dementia. What's not the metabolic component of Alzheimer's is a vascular dementia.
Yeah. So, yeah, people, there's a correlation with vascular disease and heart disease. There's no question. That doesn't mean it's heart disease. It's vascular disease.
Right. I agree with you. So tell me in your practice how you address nutrition for your patients, right? We've talked that this is largely a metabolic problem. What is your kind of like boring, I say this 100 times a day to patients in terms of how you help them reverse their metabolic risk for developing vascular disease?
Well, let me go back to my own origin story for a minute because I had to learn some stuff there too. As I said before, I was a low-fat guy,
Mm-hmm.
and we knew it was all calories in, calories out, right?
Obviously.
And
I say that
and the
tongue in
more
cheek.
Yeah. So the more calories a food had in it, the worse it was. Well, that was not exactly what happened with me. I stayed thin, but I still got plaque. And so I began to look at something else. I had a fellow on the channel about a year ago, named Robert Lustig. You probably heard of him.
I've heard of him.
And just before he came on, he had published what he considered, and I think he was right, a landmark article in terms of what causes obesity. And no, it's not, there is truth to the first law of thermodynamics. You get more calories in, more calories out. There is some bank account component there, but we're forgetting the fact that we're human beings if we just stay there. And if you look at a lot of folks like Lane, whatever his name, I can't
Lane
remember.
Norton.
Yeah, Lane Norton and a few other folks just say they want to ignore the fact that we're human beings, we're biological creatures.
Well,
And
and it's not an explanation. I mean, I tell like my patients, it's sort of like saying that the boat is sinking because it's taking in more water than you're bailing out. Like, while that is true, it's really not an explanation for why you have so much water coming into the boat, and it doesn't really help you fix that problem. It is a truism that is not helpful.
it is. And that's what I found out at age 57 when I found my plaque and started looking around and saying, well, something else. It's not just because I'm getting old. There's got to be something associated with this aging that's the issue. And yeah, we did an OGTT, and my blood sugars would start cranking up to like 170, 180 when I challenged my
Hmm.
my ability to metabolize sugar. So what happens is we start getting insulin resistant, pre-diabetic. And just like 75% of cardiologists, internists, and family practitioners, even these days, 10 years ago, I did not know how to diagnose prediabetes. And I had it. And it was
Yeah.
building up plaque in my arteries.
I think the other point here is that you and I still call it prediabetes, but in fact, we can detect insulin resistance long before we see an A1C above 5.7 or, a true glucose response on an oral glucose tolerance test, that OGTT you mentioned. We can start seeing the insulin spikes much earlier, right? We can see the stress on
Oh,
the
yeah.
pancreas. And just like plaque takes decades, I think we can say that insulin resistance is this spectrum that takes a long time. And when we start seeing high blood pressure, when you start seeing elevations in triglycerides, like this is that red flag. And just because your A1C looks quote unquote okay, I think it's falsely reassuring. How do you feel about that?
Oh, well, you brought up insulin response and hyperinsulinemia. And you brought up the fact you've used a few geeky technical terms. I'm going to use another one. To your point, it's really well documented that you don't have to have hyperglycemia, high blood sugar, to have
Hmm.
plaque. You can have it just from hyperinsulinemia, too much
Exactly.
insulin. And so how does that happen? Well, you also mentioned my practice. I don't do an OGTT anymore without doing an insulin response. Now, what does that mean? First of all, what's an OGTT? And by the way, for the academics in your audience that are watching it, I get this all the time. Well, I used to. I really don't get it so much anymore because I don't know. At least in my audience, I think the word may be spreading. You've heard the term HOMA-IR.
I have. I use it.
I'm a little bit nervous. Well, I'm more than nervous. I don't use it, and here's why. I see people all the time that come in and they have a great. It's a ratio between fasting insulin and fasting glucose, and people will say, "Doc, you really don't need to go through all this pain of an OGTT and insulin response because you just look at that fasting ratio." I see people with perfect fasting ratios all the time. In other words, a perfect HOMA-IR. But then we'll challenge them. We'll give them that 70 or 100 grams of glucose, depending on which format you're using. And to your point about hyperinsulinemia, you will miss about 20% of people with insulin resistance if you only look at glucose. That 20% that you'll miss will keep their glucose numbers just fine, But what's happening is they're cranking their insulin way up to do it.
Yep.
And those are the people that that fit in that category where the researchers will say, yep, you don't have to have hyperglycemia, you just have to have hyperinsulinemia. And yes, for some reason, high insulin does cause inflammation and plaque and therefore cardiovascular risk. And we see that all the time. So that's what I do. I do one of the key tests that I do. I do several tests to look for insulin resistance, prediabetes. And to me, I call them the same thing. If somebody comes in and their blood sugars are absolutely normal, even when you challenge them, if their insulin's going up to 90, 100, even significantly above 50 at that 1 hour
Yeah.
challenge,
Yeah.
I'm telling them, look, you've got hyperinsulinemia and therefore insulin resistance, therefore prediabetes, therefore vascular risk.
And what's your approach to helping them manage that?
Well, it's not, I don't lead with supplements, I'll tell you that.
Good. I like that as a start.
And that's one of my favorite terms. I was having a conversation with a friend before this meeting, Dr. Johnston, and one of the questions that came up is, what's one thing that you see people do that you just wish they wouldn't rely on? And it's like, maybe one of the most common things I see is people saying, maybe I can't, this is too hard. I don't want to control my diet. I've got diet problems. I don't want to exercise because that's too hard and I don't want to work up a sweat. So I'll just take a supplement. Well, I wish it were that easy, but it's not.
Yeah, I just recorded a whole episode on supplements, and it's really just my philosophy on supplementation. And one of the big myths is that you can have an easy button, right? It does not replace the simple but challenging work of altering our lifestyle.
Now, I came to this space 12 years ago with a very popular perspective, especially among academically experienced docs, and that is supplements are just expensive urine. I got my nose punched in on that one because they're so popular on the internet. So you get on something like YouTube, you start talking like that to maybe understate the case. You're going to get challenged a little bit. So I did respond to these challenges and I started looking up supplements. And sure enough, I found out that there is a place for supplements. They're not expensive urine, but they're not the go-to. You cannot out-supplement a lifestyle.
Right. I mean, they are drugs. They are unregulated drugs, and some of them have some good efficacy that's worth knowing about. I agree with you there. But I would argue we should treat them like drugs. They should have a specific indication. They should have a measurable outcome, whether that's a symptom or a lab value, some kind of clinical outcome. But, that's how I treat them in my practice.
Me too.
So how are you helping people with lifestyle to manage insulin resistance and prediabetes and diabetes? What do you tell them to do?
Well, what do we tell them to do? One of the key things that I'll say, because I talk so much about plaque, and that video that you described, my origin story, was for years by far the most popular video on the channel. We've gotten a lot more since then. We've changed a lot of what we do in terms of the, video contents, things like that. But that story's still the most popular. And the bottom line is there's a little bit of no pain, no gain kind of thing, at least no discomfort, no gain. The channel has gotten popular enough to where we get way more demand than for patient care than I can see personally. We've got a group of about a dozen well-trained prevention docs that have been trained by us, docs that know the space. Jesus, who you were talking to before the show, is prevention trained. He's licensed in Mexico, so he's not a doctor here, but he works with us as a coach for a lot of patients. We have other docs like Jesus who do that, and I coach them too. Back to your point of what we talk about, there's several things. It all gets back to a science issue. The science is this. Body fat, especially visceral fat, creates a hormone that helps cause this problem. It's a hormone that's called resistin, and it does exactly what the name says. It's well, we can talk about it again in a minute if you want. Likewise, so body fat is a major killer here.
Yeah, and I think specifically visceral fat, right? The fat that accumulates around our organs. I've talked about this. It's pro-inflammatory. It is different than the stuff you pinch under the skin. I mean, nobody likes that, but if it's there, it's much less likely to generate these inflammatory molecules, these cytokines that get into the artery wall that retain our ApoB particles that then oxidize and turn into plaque, right?
So to your point, we're very, very numbers driven. I get a lot of engineers because
Yep.
another origin story thing. I was at Toyota for a decade, Toyota globally. I was the medical director for basically the Western Hemisphere. And at my level, we had a lot of internal coaches. And I remember one of my coaches saying one time, yeah, we know you're a doctor, but you're really an engineer. You think like an engineer, you're a numbers guy, et cetera, et cetera. You do things like we do in terms of preventive maintenance, et cetera. And that's actually the way our practice runs. It's a preventive medicine PDCA, plan, do, check, act kind of thing.
Mm-hmm.
But the numbers that we look at, 2 pounds or less of visceral fat, it's really clear. That's 2 pounds is your first goal, and then you get less if you can. Mine tends to vacillate between half a pound and a pound. You get
And that's based on a DEXA?
Yeah, and DEXA.
Okay.
And there's a whole bunch of other technologies that claim to be able to do it, but they can't. And that's the discussion as well. And then 20%, start with another goal of 20% total body fat, and then go from there. So it's a very, very numbers-driven practice. The only way you're going to get to those kind of numbers, by the way, is managing your lifestyle. There's not a single supplement that's going to get you there. You got to do the hard work. You got to do the intensity. That's another thing. Walking is not going to get most people there. Just a little bit of strolling in the mall. So the other thing that we look at on that DEXA, by the way, is muscle. Metabolically healthy muscle is your best internal safety valve against this disease. Now, what do I mean by that? Well, microvascular. Let's get technical for a second. You guys are geeks, sounds like, and they talk about vessels a lot because that's what you do.
Yep.
Microvasculature is of the muscles is what goes. It's a major, not canary in the coal mine, so much as mechanism for loss. And we've always known it as, quote, another one of those normal impacts of aging. We also know that loss of microvasculature for muscle is a big deal for metabolic disease. So, and I personally think it's one of the areas where metabolic disease is actually the major cause of, quote, normal aging, and that's one of those things. So how do you manage microvasculature, and what is it? It is the capillaries that penetrate your muscle tissue. And when you begin to think about it, it's like, so what's so important about those? Well, that's where the insulin receptors live. That's where the blood sugar goes from the blood, where it can rot your arteries into the muscle, where it's going to be safe and not cause you any health problems at all. So that microvasculature for your large muscles is critical. And you're not going to get that, by the way, from diet. Although I'll acknowledge from the beginning that diet is the most important part of health. You can have your diet completely dialed in, but unless you do the intensity in terms of exercise, you're not
Yep.
going to regrow those lost muscle capillaries.
Yeah, I tell my patients muscle is the biggest sink or user of glucose in the body, but you have to have enough muscle and have enough of those capillaries to actually dispose of that glucose effectively. And to do that, we have to build some muscle. And especially for my slightly older patients who what I would call sarcopenic or don't have adequate muscle mass, and who, again, sort of acknowledge that as just a regular part of aging. I say, look, I strength train with my mother, with my father, 2 days a week. It is possible. And if you took an MRI of my mom's thigh muscle, you would not be able to tell that she is in her 70s. Like, she just rejects this idea that aging is inevitable, and she trains really hard, and it's impressive.
Good for her. And you mentioned another critical piece where you're not talking about her arms so much. You're talking about that thigh muscle. Why is that?
Again, we're just looking at where do we have the biggest mass of muscle in our body, and our legs that propel us around tend to have a lot of that.
So you asked me before, what do we tell folks to do? That's what we tell them to do. We start talking about muscle, and they obviously start thinking about their biceps. And the biceps is tiny. I mean, look at Arnold Schwarzenegger or your typical successful bodybuilder. They may have what looks like a huge bicep, but compare that bicep to their thigh. No comparison.
In terms of nutrition, what would you, so my engineers want something to track, right? We can do DEXA, but that's only every couple of months. They want something to do every day. Are you asking them to wear a CGM? Are you asking them to track carbohydrates, calories? What, as you counsel people on nutrition, what are you asking them to track or monitor on that front?
Well, when you realize that, and so go back to Robert Lustig and his article, there was four things. One is overall calories, but the second is the carbohydrate insulin model. So we know that insulin, we've discovered that hormones are critical here, and insulin and the insulin related hormones are a critical piece. So carbohydrates are what stimulate insulin. Protein, maybe a little bit, but I think that's a little bit of a red herring. I think the biggest issue is carbohydrates. And as you and I mentioned before, it's not watch how much sugar you put in your coffee. It's watch the bigger sources of carbohydrates, like that that cereal, that cold breakfast cereal that 80% of Americans still eat.
Is it that
That's
high?
what that's nuclear in terms of your arteries, your vasculature. So yes, to get back to that, the question is, how much time is your body spending over 120? Is your blood sugar spending over 120? And that's clearly a CGM, a continuous glucose monitor. And so all of my patients use them. I use them. Now, believe it or not, there's so many things about medicine that have been quantified. The new advent, CGMs, continuous glucose monitors, have not been around that long.
Right.
I remember having my own arguments with FDA when they were dragging their feet. Canada and Europe got access to CGMs like 4 years before we did in the US, due to the infinite wisdom, yes, sarcasm included, of the FDA. Now, I get it, and I realize that CGMs do have their technical problems here, but you're really, that's core to our practice and what we're doing. There's data about how much you need to know your blood sugars. Even before CGMs, they looked at how much data somebody needed to know to manage their blood sugar very well, and it was like 25% of the time. So you don't need to be using a CGM all the time, but you do need to be using it. I'll recommend to my patients for the first year, start off with 2 of them in succession, then do 1 a quarter, and one every 6 months, probably every 6 months after that, because the aging process, growing old's not for sissies. And one of the
I've heard
biggest
that.
issues, yeah. And one of the biggest reasons behind that is that people expect us to just slowly get more and more insulin resistant as we age, and that's not what happens. I can tell you from following my patients, they go along healthy, they're fine, they think they've got this licked, and they do, and then all of a sudden their insulin resistance cranks way up. So
women, especially postmenopause, that's a thing. Estrogen contributes to insulin sensitivity.
I had a woman psychiatrist that was doing great in terms of her insulin values. Well, not great, comparatively great. You'll see the rest of the story. She would crank along about 70 or 80 in an as a peak in an OGTT, oral glucose tolerance test, and an insulin response. So we knew she had some problems. Her issues were really more in her sugar levels, but then there were a couple of other problems, which I won't mention. Inflammatory problems, though, and sure enough, the next time we did an OGTT, and insulin response, many people call it a Kraft insulin survey. The next time we did one, her insulin responses went up to 170 and 180.
Wow.
So, yep, that's what we'll do. We'll have people monitor them at least quarterly or every 6 months, just to keep an eye on it and make sure that they haven't hit that bump.
Was it menopause for her, or was it something else that triggered that?
No, it was a disease that we now know contributes significantly to vascular inflammation.
Got it. Yeah.
And I mean, again, you're way deeper into a lot of areas of this space than I do. Like lupus, rheumatoid arthritis.
Yep.
Psoriatic arthritis. I have a ton of patients that come to me that have psoriatic arthritis, and their rheumatologist, their inflammatory disease doctor, is following their CRP, C-reactive protein, that bioindicator of inflammation, vascular inflammation, and I'm following it as well. We're both watching that CRP for that patient. But more recently, we've even seen things like some infectious diseases like COVID being associated with vascular disease. So,
and are you driving those people even lower? I mean, towards a ketogenic diet, towards like an elimination carnivore type diet, or are you just still mostly focused on glucose and insulin values? Like, how do you think about that?
So, to me, I think it's pretty simple. If you're at a place where you're insulin resistant, and we know that insulin, hyperinsulinemia or hyperglycemia, causes this problem, vascular inflammation, then maybe you shouldn't be eating things that raise your insulin or your glucose. And yes, you want to make a guess on what portion of my patients have that?
Let's call it 80 plus.
No, I would call it 90, 95 plus. So, if carbs are making you create insulin or high glucose and therefore inflammation, then you need to slow down on your carbs. So at the end of the day, I've got people in tons of spaces. You've got a range these days all the way from carnivore or lion diet on one end, lion being somebody that eats only ungulate meat, all the way to vegans on the other end. And I've got people in every group.
Yeah, me too. It's interesting.
It is interesting. The carnivores are the most vocal these days. And my perspective is, look, I don't really care where you get your sources of macronutrients. What I do care about, though, is this. If carbs are hurting you, you need to slow down on them. And I'm also I'm not a paternalistic doc. I'm not an authoritarian doc. I see patients, and I go through this with them. In my perspective, they're Luke Skywalker in their movie. This is their movie, their life that they're protecting, their family security that they're protecting. So they have to make the decisions. And that's
Mhm.
really, not only is that just a human value thing, it's common sense. If the big things are lifestyle, I'm not going to be there to make the lifestyle choices for them. I'm not going to choose what they eat for breakfast, lunch, and dinner. I'm not going to choose when they fast. I'm not going to choose how much intensity they bring to their workout. But they may be Luke Skywalker. I'm Yoda. I've been in a whole bunch of those same battles, including the same battles for my own life. And I know the tools better than they do. I know the background, I know the situations, and I will share that information with them.
I can't think of a higher note to end on. I want to make sure people can come find you. So let me know what you are most excited about in your practice these days and how our viewers and listeners can find you if they want to learn more.
Oh, well, again, we'll send you some information. All you have to do is look up my name and the channels, Ford Brewer, and find that, and any of the below the channels in the description, or below the videos in the description, you'll see a call to action or a place, usually a link that you can click on. Thanks for asking what I'm most excited about. So here's the thing. No matter how big we get, we can't, I mean, right now we've got about 750,000 subscribers. But if you look deeper at channel statistics, there's several million people that are aware of what we do. There's no way we can treat that many people. So one of the key things that we're really excited about is something that's already happening. If you go talk to somebody, man on the street, especially a YouTuber geek or some other type of person who's interested in medicine and what we're talking about,
Mm-hmm.
you'll see they'll go to a place like Function Health and buy a bunch of labs. They'll
Yep.
get the labs, then they'll take them and they'll put them in Chat GPT. And there's some good and there's some bad to that. People accuse me, because of what I do, that I'm stimulating or enabling do-it-yourself medicine, and I would say not exactly.
You need
Do-it-yourself
a Yoda.
medicine.
You
Yeah,
can
that's exactly
train you on your
right.
own, but you need a Yoda.
That's exactly right. So what we just described, taking it to figuring out, getting your own list, ordering selecting for yourself the labs that you get, and then taking it and sticking it in something like ChatGPT, that's do-it-yourself medicine. What I'm doing is something that's very, very well documented. It's patient-centered medical care. And it's demonstrated time and time again that if the patient is in the driver's seat, the patient is making the decisions, the patient understands the decisions, their outcomes are going to be far, far better. So what we're
100%.
doing is we're replacing that. We're rolling out a program where you can get your labs, the lab requisition, the order sheet from us, and then you can plug it into our version of ChatGPT. It's not just
Mm-hmm.
ChatGPT. It's our own AI. And so you plug it into a regular ChatGPT, you're going to get what is on the internet and what you and I talked about.
Yeah,
Oh,
your
it's
A1C
all,
isn't 6.5, you're fine.
or even worse, your cholesterol is 70, so you're fine.
Oh, yeah.
Or your cholesterol is 125, and therefore that is the problem, and you don't have to look any further.
Right.
So there you go. Thank you so much for having me on board.
But we are absolutely going to have you back. We didn't cover half of what I wanted to dive into today, and I know the audience will want more. We will arrange a time to do that. Thank you so much for making time to be here today, Dr. Brewer. It's been an honor to have you.
I appreciate that.
Take really
Bye-bye.
good care. Bye.